So as I said, there's this controversy about whether hemiarthroplasties are over, and there are several surgeons I know from Germany and France who would refuse to do a hemiarthroplasty. Can I have the next one? The reason for that was that the hemiarthroplasties don't do very well on the comparison studies against reverse shoulders. But you must understand, these are papers based on patients who are 70 and above. So we'll share a case regarding this. Go on, Sunil. Next one. So this is a 45-year-old lady, diabetic, politely plump, I would say. And then she's had this fracture. It's a fracture dislocation, a difficult one. Next click. The surgeon went in and did a half-hearted job and realized that this hasn't come through well. He spoke to his senior, and senior said, this is not on. And on the very fifth day post-op, they went in and did a monoblock hemi on this. So can we have the panel on this and tell us what went wrong? Sunil, hold on. Yeah, you can go on to the next slide. And then we can discuss with the panel.
So yeah, so the floor is open to discussion. So what went wrong here? So if I go back to the previous slide, if I go to Amit first, I think this is a 45-year-old lady with this, I think, fracture dislocation of the right shoulder. You can see several parts. The humeral head is lying under the coracoid. The greater tuberosity is off, the lesser tuberosity is off, the proximal humerus is in bits. And obviously they've tried to fix this, and you can still, and even after the hemiarthroplasty, you can't see the tuberosities aligned. What do you think?
Yeah, so
went wrong here?
Thanks, Sunil. I think the first thing is that this has not been reduced properly. We have this constant problem in proximal humeral fractures where the plate sometimes is being asked to do too much. The first thing is that we needed to get this well reduced and properly fixed. And if that had taken place, then the second half wouldn't have happened. But after having now lost the plate, the failure of the fixation, the second part, which is proceeding to a monoblock prosthesis like this with zero tuberosity, no cuff, it's almost doomed to failure. Really, it wouldn't have worked out. So I think that's where the problem started with the original surgery, I think, but the next steps taken were also inappropriate, leading to where she is.
I would say that. Do you think that a further sort of investigation form of a CT scan would actually help you decide whether this was a head which was salvageable by fixing it or not? So, but we obviously don't have that advantage, and maybe the decision was to be made on that CT scan. Yeah. And but what are your thoughts, Shantanu, on this?
Yes, I agree completely. Personally, three-part fracture dislocation, which is what this may be, the lesser tuberosity may still be attached to the head, is verging on the unsalvageable. And then we need to see the physiological age. There's everything is wrong with this, Ashish. I don't know if this was the first post-operative check X-ray, because the humeral head either was never reduced or it was reduced and it has migrated again. I can't see the tuberosities. The hemi doesn't seem balanced. It is posteriorly subluxed on the glenoid. I can't see anything right in this, rather than saying what is wrong.
Shantanu, do you think, do you think we could have just revised the fixation and put another plate back in?
No, so I was doubtful.
The first failure.
Yeah, Ashish, I was doubtful even in the first time around whether this was a salvageable head. And therefore, to me, the answer here, after a 3D CT scan, would have been either a hemi or a reverse. But she's a bit young for reverse, I accept that. But I don't think this head is easily salvageable.
Yeah, I mean, Ashish, I think we've got to look at, obviously, the physiological age of the patient as well. Salvageability of the head in a dislocated scenario is, through a fixation, is going to be very poor. The outcomes of these are known to be riddled with AVN, secondary malunion, non-union, all kinds of problems. So I would probably have, again, gone for either a hemi or a reverse shoulder. I would have considered a reverse shoulder if the patient was physiologically a bit older than her years and she was overall a low-demand patient, on the basis that this would be the best option for her to get the maximum out of her arm.
Ashish, do you think the X-ray you've shown us for the hemiarthroplasty, this is after a few weeks or months? Because I can see there's sclerosis around the greater tuberosities, maybe it was not reduced when the hemiarthroplasty was performed. And
actually, this was done elsewhere, Sunil. And if you look, the staples are still there. So the history we got was she came to us 3 years later. And this was a 5th post-op X-ray,
okay.
5th day post-op. And so the staples are still there. It's just a poor execution and knowing that she was 45, young diabetic. She's not physiologically very old, except for the comorbidity of diabetes. But as you said, the presence of fracture dislocation suggests as a high velocity injury. So the rotator cuff would have been involved there.
Right, let's move on. Went one wrong.
Move on. Yep. So then after 3 years, we were not left with any other choice because the GT was not salvageable. I find that I can salvage the GT if it has come within 4 to 6 weeks of the previous surgery or the injury. After 6 weeks, it can be very difficult to pull it back and fix it in there. So not a very happy option, but we had absolutely no choice. So I would be in a dilemma if she had come to me immediately after that hemi. But because she came out 3 years, I think everybody will agree that the reverse was in position here. Can we go to the next? Right. Sunil, you will have to click on the second video as well on the right side.
Yep.
So you can see on comparison, there when we saw her on day 1, she had absolutely worse than pseudo paralysis. Any chance you can get the right one moving? Just need to click on the right frame, the second right half of the
Yep,
screen.
we'll try.
Or just press next, it should work.
Yep.
Yeah.
Getting it now.
There you go. Yeah. So she is now till date 2-year post revision reverse shoulder replacement. You can see that she's not old, really speaking, but she has an active profession. She's a teacher at the school, and what has been alarming was she's just not able to lift her arm up to write on the chalkboard and stuff. So that has damaged her self-respect. But fortunately, even though late, we've done. She's 5 years after the original accident, but 2 years after the revision reverse. The problem with the reverse is the lack of rotations, especially if the tuberosity is not there. And we didn't have anything there to repair as such. So although her actual movements are reasonably good, we could offer her only this much on terms of rotation. She's fairly satisfied because she came from nowhere. So that wasn't too difficult. Next slide, please. Yeah.
Ashish, there's a very quick question from Mr. Khurana, one of our surgeons from Great Yarmouth, and he is asking that, did you get a chance to feed back the regional surgeon about what went wrong?
Actually, we are not in direct contact, but we gave a lengthy letter to her explaining the problems, and we did ask her to touch base with the previous surgeon, which she did, and she had several dialogues before she agreed for surgery to come to me. So he was in the loop, so indirectly he is aware of the problems, and I'm hoping that he read the letter that we gave her.
Thank you.
Yeah. So as I said, just last 2 slides here. Again, deltoid split was not the option. It had to be deltopectoral, certainly because it was a revision surgery. I do use the deltoid split for reverse shoulders frequently, but whenever it's an extensive approach, then I would always use deltopectoral. And sometimes we need to do a Leopold to give back their external rotations. But in revision surgeries, I don't think we have any control over the lat dorsi, which is usually scarred down. I think most of us will agree on that. Next slide. Thank you. That's done. I'm done on my side.
Lovely. Thanks a lot, Ashish. We've got 30 minutes now. So what we'll do is we'll come back to you, Ashish, after the other two talks, if that's okay.
Sure.
So
Sure.
thank you very much. So if you can move on to Shantanu Sahane's slides. Shantanu's got an excellent case on double fracture of shoulder and elbow.
Clicker.
Sudhi, need the slide?
Oh, sorry. Sorry, Shantanu.
He gave him the clicker.
Yeah.
Ladies and gentlemen, good afternoon. Thank you very much for the invite, Amit and the whole BIOS faculty. We have 5 or 7 minutes to just discuss an unusual case. This came quite recently. It is a scapular and elbow fracture in the same arm. I work at Chesterfield and Sheffield Children's Hospital, which is my pediatric shoulder and elbow practice. I do some work for the University of Sheffield. And recently, for my sins, I'm a medical director of our One Health group in Sheffield. This is a 58-year-old lady who suffered a fall down a stairs, simple injury, but very high velocity, a few steps down. And she sustained, which is quite an unusual fracture. I haven't seen this quite commonly. It's an extra-articular scapular neck fracture, which was completely displaced. And the terrible triad injury of the elbow, we see it quite commonly. And therefore, I thought this will be a good discussion topic for this sort of session. She was intact neurovascularly, and the elbow was reduced, following which the x-rays were taken. Back slab applied, patient was then presented in the trauma meeting next morning. The question here comes, how do we proceed with future management? So this was the initial x-ray of presentation, which was slightly confusing because I thought you could see the glenoid nicely, but then there was obviously a large double shadow in the front. And as I said, this is not the common fracture pattern that we see in this. And the elbow post-reduction showed what appears to be a fairly large glenoid fracture on the, fairly large coronoid fragment in the front and a comminuted radial head fracture. So the question then came, how do we start managing? How do we prioritize? And I'll come back to the learning points at the end. Before it was shown to me, she had a 2D CT scan. And again, you can see a very large coronoid fracture and the radial head, which seems multiply comminuted. I am a real fan of 3D CT scans. This is a separate patient. The other patient did not have a 3D CT scan because there was an urgency to fix it, and we had a slot. But the 3D CT scan has transformed our management. So this is a different patient in which you can see how the radial neck is fractured, but the radial head is intact. And it gives a really good idea as you turn the images around. So to me, 3D CT scanning has now become quite imperative. Going back to the previous patient, we obviously did the procedure in staged fashion, and we did a radial head replacement. And I'm showing you the final x-ray, and I'll come back to the learning points later. If a radial head is in more than 3 pieces, in my hands, it is unsalvageable. With 3 pieces, sometimes you struggle. And with 2 pieces and a radial neck, you can just about do it. This one was not salvageable. To me, initially, a radial head replacement in younger patient was a taboo. It is not anymore now. I have really no lower limit. If it is not salvageable, I try not to do a bad fixation. It is better to do a radial head replacement. The reason I show this slide is because 2-screw fixation of the coronoid is quite rare. And this was such a large fragment, we actually got a fantastic hold with 2 screws. And the final point in this is, nearly always the LUCL is avulsed from the humerus. And if you can isolate it and do it fairly early, you can primarily repair it. If it is not repairable, I will give you examples of what we can do later. So this came quite nicely. You can see a little drop sign. You can see a little bit of a gap between the humerus and the coronoid. And this is the drop sign. I do not worry about it at all because as soon as the patient wakes up and the brachialis starts contracting, the drop sign corrects itself. It's important not to stuff the radial head too large or too big. This is not the projection. It looks like this. I'm very careful to keep it more floppy rather than too overstuffed. Next was this. This was an interesting problem. And as you can see, the 3D CT scan tells you a very substantial injury. The entire scapular neck has been fractured, and with an intact glenoid cartilage has been translated anteriorly. I can't remember many examples of such complete displacement. So in this case, we did that rare approach, posterior approach to the shoulder. I don't know if my pointer is showing to you, but this is the arm going this side, and the head is on this side. The patient is in a sort of a semi-prone position, and you can see the stay sutures on the posterior deltoid, which have been removed from the back of the scapular spine. The second approach shows an infraspinatus, which is a very bulky muscle. Second to subscap, this is the largest cuff muscle. And between infraspinatus and teres minor, you can find a nice plane. Suprascapular nerve is here, axillary nerve is somewhere there. Once you find that plane, the procedure actually becomes quite easy. I'm just going to show you this video, which shows the deltoid nicely reflected with a nice flap posteriorly, and this is the infraspinatus. Be very careful that fat raphe you see in infraspinatus is not the gap between infraspinatus and teres minor. The gap is quite lower down, as it's a multi-pennate muscle, the infraspinatus. And once you have found it, the procedure is very easy. We harvested and found the glenoid lying anteriorly. And it was quite hard work to relocate it back. And personally, I use the Acumed contour plates, which are fantastic because it gives us a lot of hold proximally and a few distally. And this is the post-op X-ray. This patient's only 4 months down the line, and I'm hoping to get a CT scan done later to see it was okay. So the terrible triad of the elbow, we are all aware of it: a dislocated elbow, fractured coronoid, and a radial head fracture. And just to mention it, and I'm sure all of you know this, we don't need to say this more, but the sequence of events is to reduce the elbow urgently, assess the stability, and fix the coronoid if required, and I'll come to that later in the learning points. And all of us are aware of the Mason classification. That still remains my way of treating a radial head fracture. The coronoid classification has changed, which I will come to now. When I became a consultant 20 years ago, Regan and Mori was my classification. And I still teach this to the students because in FRCS, this is what is asked. You have a flake of bone anteriorly, which may be fixable or may not, in which case you take a capsular stitch. Type 2 and type 3, if they are large fragments, you can fix them. Very, very rarely do I need a specialized coronoid plate, and it's only in a posteromedial rotatory instability where you need that, but otherwise screw fixation is quite good. This is just a quick off slide. This is a separate fixation. I have completely gone off radial plate fixations. So if I can salvage the radial head and neck, I do a T-pod fixation. I do a T-pod fixation in which the 2 fragments of the radial head can be fixed with the neck, and the 2 fragments of the radial head can be fixed with each other with a headless screw. And I'm very, very pleased with this outcome. I cannot last remember when I put a neck on the radial head plate. It is a problem, and we'll discuss that later. And this is another case just to show that if the screws are too small, then you can use anchors in the coronoid, and you can have a capsular stitch go through it and provide stability. So this is just going slightly off tangent. I think we are all aware of this. The only reason I put it is the outside circle is the ulnohumeral joint, anterior band of MCL and LUCL, which are the primary stabilizers. And inside is the radiohumeral joint, common extensors, and common flexors. In the outside circle, if you see the ulnohumeral joint, LUCL, and anterior band of MCL, 2 of the 3 have to be restored normally. If you restore 2 normally, the third often heals. And invariably, because the approach is often lateral, I try and restore the ulnohumeral joint and the lateral ulnar collateral ligament, and the MCL heals nicely in a cast brace. I have not had a problem with MCL non-union or needing it reconstructing many times. So the last 3 slides, what are the general learning points? Firstly, it's a staged fixation. I did elbow first here because in trying to fix the scapula first, I may have made the elbow unstable. So I did the elbow first, and over a couple of days later, we did the scapular fixation. As I have mentioned before, 3D scanning is very useful. And I strongly believe that these surgeries are left best in the hands of people who do this more frequently in daylight hours. This is not something to be undertaken late in the night and by a non-specialist surgeon. What are the elbow learning points? As I have mentioned before, radial head fractures are fixable only if the radial head is in 3 or less pieces. I have already mentioned the radial neck fractures. I don't fix it with a plate because I just think finding that little spot, which is the non-articulating area, is not easy. Patients get crepitus, and invariably in my hands, it becomes a 2-stage operation. Fix it. When it heals, take the radial head plate out and then do an arthrolysis. So it's either my deficit, but I have found problems over years. And finally, some kind of coronoid fixation always is needed. That may be a capsular stitch or a screw fixation or a plate. I don't use Regan-Mori classification. O'Driscoll has classified, which is too complicated for me, but I use the Wrightington classification, which is fantastic. It's a 3-column classification, and that has again transformed my management. It's not appropriate for this meeting, but I would recommend that we read that to manage coronoids. And if I can't repair the LUCL primarily, I always have LARS on the shelf, which is the polyester artificial ligament reconstruction. It's a fantastic stable fixation, and it can allow early mobilization. And finally, the shoulder learning points. Please be familiar with posterior approach amongst the shoulder surgeons amongst us. And the important thing is to be aware of the neurovascular planes and the structures. I never use self-retaining retractors deep inside. That's the single biggest recipe for neuropraxia. Even if the scapular neck is displaced anteriorly, there is very little plate due to the presence of subscap to put a plate anteriorly. Therefore, we approach posteriorly, and once you reach through the gap, I think fixation is quite easy. And I always use pre-contoured plates. A recon plate or a DCP is not appropriate for scapular fixation. And as Ashish has already said, I think a very diligent, specialized therapy input post-operatively is absolutely mandatory. We've had a very difficult year. I don't want us to see these pictures of ventilators and compressed air and the masks anymore. And we hope we are moving into a nice, pleasant world. And we hope that in BIOS we all meet face-to-face next time. Thank you very much.
Thank you, Shantanu. That was brilliant. We've got a couple of minutes for some questions. I just want to start off asking you about what you've already touched on briefly. So scapular fractures are generally treated if they are well aligned conservatively, but obviously in this kind of fracture where the neck was anteriorly displaced significantly, almost off-ended, you obviously chose to fix it. In most of the DGHs, the shoulder surgeons like myself are not very au fait with the posterior approach to the shoulder. What's the window of opportunity you have to fix these fractures, and do you think we have enough time to refer them to tertiary center in lines with GIRFT?
Yeah. So thank you, Sunil. That's a useful question. In this case, the window of opportunity was not great because the scapular neck had moved anteriorly, but the humeral head had stayed back. So it was actually rubbing on the raw exposed neck. So I thought initially the whole humeral head had moved with the scapular neck, but it wasn't. And therefore, there was a reasonable urgency, but then it was complicated further by a very unstable elbow. So, and I didn't think an elbow terrible triad fixation and scapular neck fixation in one stage was appropriate. The positioning, the whole length of operation, the anesthetic was a problem. So we did both of those within 72 hours. Getting it right first time, you talked about GIRFT, and I think if you're familiar with the approach, I don't see any distinction between a teaching hospital or a DGH. And at some stage, we have to do it first time round. And I think we touched on it earlier. I think this may be an occasion for two surgeons operating, and I think you need two colleagues who know what's going on to do it together.
And with regards to the elbow case, what's your, for those the trainees join us, what's your approach for the lateral, so for fixation of your coronoid and for the repair of the collateral ligament and radial head?
So when I started, I used to use a Cocker's approach, and I think the Cocker approach is just too posterior for radial head, and I used to struggle with the anterior exposure. And Kaplan approach, which is the approach I use for posterior interosseous nerve decompression, is just too dangerous an approach, and I just don't want to see a single wrist drop after this thing. So I have now modified this, and it is now written up, well established, the EDC split approach. Yeah. So it is between the Kaplan and the Cocker's approach. It is fantastic. And it irks you when you go in and you see a nice healthy muscle and you split it when you think you can just go above or below and have a proper plane, but split the EDC and go through it, you will have a very good protective envelope anteriorly for the pin nerve, and you will not be bad enough posteriorly for a Cocker's approach where you're continuously retracting. So EDC split is my approach, and that is very useful because when I do arthrolysis of the elbow, which is the same EDC split approach which continues onto the column, onto the lateral humerus. So I come straight down from the lateral humerus, EDC split, and reflect the whole fascia from arm to the forearm as one. Replacing it is beautiful. So it gives me perfect approach between radial head, LUCL reconstruction, and coronoid.
Yep, thank you. Unless there are more questions from the panel, I think we'll...
Yeah, I'll just ask one more question. What do you think, Shantanu, is the incidence of medial collateral ligament injury in these injuries? Because I believe it's a bit of an overhype, yes, and you don't see so many of them, particularly if you've got a coronoid fracture, which is the type 3 Mason, where it's lifted off. Yeah. Then you start thinking whether the medial collateral ligament has also been lost, and would you assess that on table?
Yeah, so I always assess and do an EUA post everything fixate. But after everything has been fixed, the problem with assessing neurovascular, the stability status with the patient asleep is a bit tricky. I showed you the drop sign. The drop sign nearly always vanishes when the patient wakes up because the brachialis works. In 20 years, I have done 3 or 4 medial collateral ligament reconstructions. And they have always been delayed reconstructions where I just think that's not right. But it's just a rare problem. In America, it is a bit overhyped because of baseball pitchers and the MCL is so commonly repaired by them. So I don't think we have a major problem.
Okay.
I don't think.
Thank you.
There's a question from David Plain on the chat with regards to the internal joint stabilizer.
Say that again.
Yeah. So there's a question about do you have any experience of using the elbow internal joint stabilizer in these cases?
No. So I have seen people use it. I have not. The only comment I would make is an external fixator of this. So when I initially started I never used to do terrible triad without an X-fix on the shelf. I have never used an external fixator. Internal stabilizer is a different ballgame altogether. I have no experience in that. But just to mention that if you do a proper internal fixation and repair the capsular and soft tissue structures, very, very rarely will you need an external fixator.
Thank you. Last question before we move on to Amit is, when you are fixing the elbows, is your patient supine with the arm out,
Yes.
or are you lateral?
No, always supine with AMA.
Okay, lovely. Thank you, Shantanu. Thanks very much. Right, let's move on to Mr. Tolet, who will give us a treat on another excellent case. Thank you, Amit.
Thank you. Thank you, Sunil. And thank you for your very generous introduction. So I'm going to show you this case, which is not an uncommon presentation. There's a 52-year-old man who's a well-controlled diabetic who fell from a height. And we all agree that this is a TY fracture of the distal humerus. There may be a slightly greater degree of metadiaphyseal comminution, but this is an unstable injury, and one would just go ahead and fix this, right? So there we are. He had a fixation. I don't think one can knock that back to any great extent. One has good distal screws, a plate which bridges both medially on a pre-contoured of a pre-contoured type, and then a posterolateral pre-contoured plate. You got satisfactory reduction and fixation, and all seemed to be well until 3 months later he came and the posterior pre-contoured locking plate has failed through the vacant hole. He was in quite a lot of pain and discomfort at that point of time, and there are various thoughts that cross as to what are the next steps, and I think most of them we decide that this is probably the best option, revision surgery with a long LCP and bone grafting. And again, you can see that the reduction of the fracture remains satisfactory. The plates have been revised, and all seemed well for a little while until he comes back 1 month after this, and there is a plate breakage. Now the posterior plate has again fractured, and on the medial side, the screws have sheared off, and you have this big problem of the diaphyseal non-union. I think the rest of it all looks good, and the intercondylar part looks to be well healed. So I think when you're faced with this situation, you probably start thinking, what am I going to do? And I would like to put forward some thoughts that might cross at this stage. I'm very happy for the faculty to add to that. So the first thing is whether the stiffness and stability of the construct was not sufficient for this type of fracture which extends into the shaft. One has to remember that titanium, which are what all these pre-contoured plates are made of, have a low modulus of elasticity, something like 20 compared to stainless steel or cobalt chromium, which is 100. And you do get a stress concentration factor of a vacant hole in a thin plate. The second thing is, at this point of time, should we rather be treating this as a shaft fracture in non-union? And then one should look at, are there any other patient factors that need addressing? I mean, there are 2 major causes of failure, biomechanical failure or failure of fixation, and the second is osteogenic potential. Is this a poor osteogenic potential? Should the patient have been braced? Is there a low-grade infection? The patient was diabetic but in good control. So there wasn't any other issues really with this man. And I think the main problem was that the stability of the construct was not sufficient for what was essentially a very comminuted diaphyseal extension of a TY fracture. And then finally, he had a LC-DCP applied and bone grafted, and the man went on to heal, and he is fine. At 9 months, 10 months post second revision, he's had a full consolidation, and there is no issue with his function. So I think one of the things that we need to remember with these sort of implants that we use is that those which are made from titanium could be potentially at a greater risk of failure if we are not able to stiffen the construct adequately. There is also an issue of a vacant screw hole. It creates a stress riser. I was interested in reading some biomechanics on this, and there is something called Peterson's stress concentration factor, which basically means that if you've got a vacant screw hole, it increases the stress by a factor of 3. The other interesting biomechanical point here is that the stiffness of a plate is directly proportional to the thickness raised to the power of 3. So if a plate was made slightly more thicker, one would probably increase the stiffness of the construct quite significantly. Vacant screw holes adjacent to a fracture site do increase this risk, and there were a few in this case in the first and second fixation. And then one has to remember that the bending forces at the elbow in flexion and varus are often extremely high, and they may not be possible to control by less stiff plates. The recent studies do show better biomechanics if you place them medially and laterally rather than at a 90-degree construct, which is what we do. But the jury is out there. I don't think there is clear-cut evidence. I think for the younger members of this online audience and elsewhere, perhaps it's important to bear in mind that T-bar fractures of the elbow, you have to follow that cookbook recipe. If you don't follow the steps, you're not going to get there. And the first part is obviously reducing the articular fracture and fixing it in such a way that it does not interfere with your provisional plate, which is fixation, which is the second step. After that, you're going to put in a screw in the lateral side, which is in a slotted hole, and that will allow you to move it up or down a bit, and then you compress the pillar across with a clamp. You need to have a good number of screws in the distal fragment, and one would recommend that you put 2 screws on either side, which are long bridging screws. The next part is obviously the medial plate, and you construct that again by placing the pre-contoured plate and putting a number of locking and non-locking screws. I think a couple of tips. You must put 4 good distal screws. They do not need to be locking because the purpose of this is to provide compression. You may run these screws across the articular components separately, but they're much more effective when put through the plates themselves. The second one is that you should try and use a home run screw. Yeah? And in this particular case on the right, there is no home run screw. You can see that the screw is very short, the plates not holding too well on the medial side, and it should have really had a long distal screw over there. There are problems with the approach as well. The transolecranon is perhaps the favored approach. I generally do favor that, but I'm just going to show a few slides on this issue because a lot of people use different approaches for this, and at the end of the day, the old proverb, you can skin a cat in different ways, and a pride of elephants has different shapes. So just in brief, you have the triceps tongue, Van Gorder, you have the paratricipital, you have the triceps reflection from medial to lateral, the classical Mori, or the lateral to medial, which was described by Deakin and Deshmukh. And then you have the olecranon osteotomy, the intra-articular and the extra-articular. But the intra-articular is the common one, and that's what I prefer to use, and a number of people do because of the huge exposure it provides to the intercondylar element. Finally, there's a triceps split and a trap approach, which is also, I would say, a limited exposure, and the paraolecranon, which gives you a wider exposure but splitting the triceps. So I think the gold standard is an olecranon osteotomy, and if you want to reduce your problems with that, perhaps the best thing to do is to use a osteotomy cutting jig. I tend to use this because this is far more effective than cutting it freehand. You can take your cut through a chevron, which is distally angled, and go 1/3 through this, and then after that remove the jig. You've already pre-drilled your screw holes, and then you complete the osteotomy with a thin-bladed osteotome to avoid damage. So what about the effect of surgical approaches on the functional outcome of open reduction, internal fixation, or intra-articular distal fractures? This paper is quite an interesting one. There were some increased risks with olecranon osteotomy, but there's really no difference between the various surgical approaches. So you can use what is appropriate in your hands and is safe in your hands, but I would probably suggest the olecranon osteotomy is a good way ahead. Thank you very much.
Thank you, Amit. Very quickly, in terms of the panelists, Ashish, do you use, what sort of approach do you use for the TY fractures of elbow? Do you use olecranon osteotomy, or do you prefer something else?
If it's a type B or type C, I go for the olecranon osteotomy. It works best because I can mobilize my patient quickly, and that works faster. If it's a type A, then I might consider a triceps on approach and work through the gutter, medial or lateral.
And do you also subscribe to the philosophy of filling in every hole in the plate, as has been suggested? And do you think that could be a stress riser? Because I personally saw there were 3 good screws, I think, around that hole. And I personally would had not minded leaving that alone, to be honest.
I don't know. I'm freaked out since Amit has shown this case. I have not had that experience, and I don't film too many screws. But it's important to have 3 screws in the proximal fragment on both columns, I think. And as Amit showed, the 2 screws on both columns going distally. I have never had a problem with leaving holes open, but I'm sure there's some other issue there with delayed fracture. If fracture unit is delayed, your mobilization is going to put in a lot of bending forces and create problems.
Thank you. Shantanu, what do you think about the
So it's interesting. I subscribe. It may be laughable, but I subscribe to the theory. If there is a hole, there is a reason for it, and it needs to be filled. And I totally agree that I think if you have an ability to fix it, you are creating a stiff construct. That's the purpose of it, so as to allow early mobilization. Now, whether that's responsible for this failure, it's an unusual failure because the first X-ray didn't look bad at all. So I would have been reasonably happy with it. But yes, if there is a hole in it, it needs to be filled. Why not? I would say why not?
Yes.
Yeah. Sorry, Vijay.
My hole is an opportunity, not a necessity to be screwed. One of the reasons what I found, having had a couple of these along, is if you go back on the X-rays, there is a lateral comminution. And what I've noticed is that if there is a lateral comminution, then that is something that will make it fail more readily than if there is no lateral comminution. And I often wonder, by putting that many sort of 3 in proximal on each side and 4 distally, whether we're making the construct too stiff.
Thank you. With those words of wisdom, I think we will put this session to close. Thank you, Amit. Thank you, Ashish. Thank you, Shantanu. And thank you, BIOS, again, for putting up this excellent session. And we're very grateful. I hope you all have a lovely afternoon. Thank you.